In this video, we'll explore the AmCAD-UO Report, an ultrasound AI assessment designed to evaluate your risk of obstructive sleep apnea, OSA. You'll see how the report analyzes airway obstruction sites and guides treatment decisions. OSA is a common but serious sleep disorder. It occurs when the airway becomes partially or completely blocked during sleep, reducing oxygen flow and disrupting rest. If left untreated, it can increase the risk of heart disease, stroke, diabetes, and even certain cancers. Traditional diagnosis often requires overnight sleep studies, but now AI-powered ultrasound technology offers a faster, non-invasive approach to OSA risk assessment. The AmCAD-UO Report's risk level indicator assesses OSA risk using upper airway ultrasound images, evaluating the likelihood of moderate to severe OSA, which defined as an apnea-hypopnea index, AHI, of 15 or higher. Green indicates minimal risk. Yellow is with a score below 80, indicates moderate probability. Red, with scores between 80 and 100, strongly indicates moderate to severe OSA, supported by 90% specificity and high sensitivity. Importantly, elevated scores, particularly above 40, may indicate underlying cardiovascular or cerebrovascular risks, warranting further diagnostic evaluation, such as home sleep testing, HST, or polysomnography, PSG. The findings section pinpoints the specific locations where airway narrowing occurs. These include velum, soft palate, a common site of collapse leading to snoring. Oropharynx, the side walls of the throat that can narrow and restrict airflow during sleep. Tongue base, if the tongue falls backward, it can obstruct breathing. Epiglottis, it collapses from a long, floppy structure, increases airflow resistance, and reduces CPAP compliance. An arch-shaped tongue can narrow the airway and increase resistance during sleep, which is detected using ultrasound deep tissue analysis of tongue mass and position. A deeper tongue in the velum and oropharynx, especially in those non-obese with BMI under 30, may increase OSA risk. A lower hyoid bone position is linked to increased airway collapse and higher OSA risk. Ultrasound imaging helps assess its position, as a lower placement may indicate hypopharyngeal obstruction, affecting breathing during sleep. The impression section summarizes key findings, providing a quick overview of obstruction risks and airway characteristics, based on detailed measurements from the findings section. The measurement summary section provides objective data on airway structure and collapsibility. Width measurements at VOT sites are taken under normal and Muller breathing to assess how easily the airway collapses. A proportionally larger tongue increases the risk of airway obstruction. A lower airspace to tongue width ratio indicates a smaller airway relative to tongue size, suggesting a higher risk of collapse. Superficial tissue thickness is measured from the skin to the superior surface of the geniohyoid. Excess thickness in the velum and oropharynx can narrow the airway and increase collapse risk. A high thickness value may indicate excess tissue bulk, especially in patients with a low hyoid bone position, suggesting deeper airway obstruction. Assessing tissue thickness helps identify structural limitations that may impact airflow and treatment options. The deep tissue analysis evaluates tongue mass. In non-obese patients with BMI under 30, a higher ratio may indicate an increased risk of OSA. This suggests thickened tongue tissue and a more prominent tongue mass, which could contribute to airflow restriction and require further evaluation. Treatment depends on how severe the airway collapse is, where it occurs, and the patient's overall health, including BMI, symptoms, and lifestyle. Lifestyle changes are often the first step. Losing excess weight can reduce airway obstruction, while avoiding alcohol and sedatives prevents throat muscle relaxation that can worsen collapse. Maintaining a regular sleep schedule also improves overall well-being. For therapy, most people start with non-invasive options, such as CPAP, which uses continuous air pressure to keep the airway open. It is especially effective for multi-level collapse, although it may be less effective when nasal congestion or epiglottis collapse is present. Another option is a mandibular advancement device, also known as an oral sleep device, which gently moves the lower jaw forward to improve airflow. When the collapse is on a single site, treatment can be tailored to that location. Tongue-based collapse may be treated with oral sleep device, hypoglossal nerve stimulation, tongue stabilization techniques, such as radiofrequency or suspension surgery, or transoral robotic surgery. Soft palate collapse can often be improved with oral sleep device, or with surgery such as UPPP, sometimes combined with tonsil removal. If the epiglottis folds back, a partial epiglotectomy can improve airflow and make CPAP easier to tolerate. In some cases, an oral sleep device or jaw repositioning surgery may also help by increasing airway space and reducing collapse. For patients with multi-level obstruction where several parts of the upper airway collapse, more comprehensive approaches like MMA surgery may be required, as it repositions the jaws to open the airway more broadly and address multiple blockage points at once. The AmCAD-UO report provides more than just a risk score. It identifies where airway collapse occurs and offers insight into potential treatment paths. With this information, doctors can create a personalized plan to manage obstructive sleep apnea more effectively. If you suspect OSA or have symptoms like snoring or daytime fatigue, talk to your healthcare provider about a proper evaluation. Better sleep means better health and quality of life.